Good morning.
Good morning, Bron.
How are you, Nat?
I'm good. How are you?
Very good. Um, Welcome to joining me with the morning tea talk today. For all
Yeah,
the way from WA, how early is
well,
it there?
it is early here. Well, it's not now. It's 7 a.m., which is, respectable. But a lovely day here, beautiful weather. What about you over there?
Yeah, it's not too bad here in Sydney. And I can see we've got a few people that have joined us.
Yeah. Well,
So
welcome everyone.
welcome. Yeah, it's very cool to have you with us. What I might do is we might start now, just mindful of keeping to schedule.
Yep.
And I know that people will join us, and I also know that we will be sending this recording out to those who've registered. So this talk today is about looking at dementia, people living with dementia, and how PACOP really can support residents and families who find themselves at end of life or with palliative care needs or end of life. To start this session, though, I'd really like to acknowledge the people of the lands that we're meeting on today. I am greeting you from the lands of the Darug people and paying respect to elders past and present, acknowledging them as the traditional owners and custodians of the lands that we're meeting on, and to their continuing cultural, spiritual customs and practices that unite us. What lands are you from, Nat?
The Whadjuk people from the Noongar Nation.
Very cool. Okay. So about dementia, I just thought initially just to talk a little bit about dementia and then the types of dementia. So it is classified as a major neurocognitive disorder. It is also it's characteristic in the sense that you can have people who have brain injuries or forgetting as they get older with mild cognitive impairment, but for a diagnosis of dementia to be made, there needs to be a persistent and progressive decline. The other thing is that we often think of dementia as a particular disease process, but it is in fact a syndrome, which means that it can be caused by a number of diseases that over time cause global deterioration of the brain. And that global deterioration then contributes to loss in cognition, function, performance, mood, emotional control, behavior, motivation. So the syndrome, it's sometimes difficult to kind of get your head around because you'd like to think of it as a unique diagnosis. And then what happens is a cluster of those syndromes can then present in a particular pattern, which is how we then name a dementia like Alzheimer's or frontotemporal dementia. What is not always well understood, is that when someone has dementia diagnosis, it's not just about cognition, where the whole of brain is involved. We look at a global deterioration, which means that function changes, performance changes, mood changes. It makes sense that everything that drives us in the brain ultimately becomes damaged. Our immune system is affected. And this is how people deteriorate when they're living with dementia and reach a point where they have got almost a catastrophic diseased brain, which then becomes susceptible to opportunistic illnesses. So how do people die from dementia? It is usually from an infection or changes that are happening from an endocrine perspective or homeostasis, but all of that is driven potentially by the brain and it goes awry. There is no cure, and this is something that people are often surprised by. Even people working in residential aged care are surprised by the fact that dementia is a life-limiting illness. So it is something as clinicians, as people working in the industry, we need to be across, we need to understand, because if we don't understand that, we definitely can't help our residents and families understand why someone living with dementia is going to end up having palliative or end-of-life care needs.
And I think, Bron, that's right. I think there is still a wide perception of people, probably outside of the health sector, that think of dementia as a state of confusion.
Correct.
Almost as in, oh, they've got dementia, they're a little bit forgetful, they're doing crazy things, but it's just so much more than that.
It is so much more than that. And I remember, that the lady who got tasered in New South Wales, I remember reading an article from a local newspaper down there, and this man talked about, oh, and she had an episode of dementia. And it's like, no, you don't have an episode of dementia.
That's right.
Dementia is your trajectory. You may have an episode of delirium, which exacerbates your dementia.
Yes.
But dementia, once that diagnosis is there, at this point, there's no cure.
Yeah.
There are over 100 diseases that may cause dementia, and that goes back to that syndrome context again. And the other thing that's important is that there is no age limit. So we often think of dementia as being an older person's illness, but it actually can be something that affects children. And in the community I live in, there is a child that goes to one of the preschools who we've watched grow and meet all their milestones and then actually lose all the milestones. And that little person's only 7 years old. So it can happen to anybody in any age group, although we see a lot more of its presentation in older adults. And with the types of dementias, these are just some of the ones that are probably more discussed and noteworthy, you know, maybe have more of a public arena. Alzheimer's disease is where a lot of the research began in dementia, but many of those organizations that were called themselves, you know, Alzheimer's Australia, Alzheimer's UK, now have changed their names to Dementia Australia, for example, which means that it incorporates all the types of dementia, acknowledging that Alzheimer's is only one of many. Although Alzheimer's remains the most highly diagnosed dementia. There's vascular dementia, which is often a lifestyle type dementia. Lewy body, which incorporates all the Parkinsonian types dementias. It also covers chronic traumatic encephalopathy, although that's listed below, they're part of the same family. And the frontotemporal dementias, which recent research is also showing incorporates motor neuron disease, multiple sclerosis. And then in some regions in Australia, alcohol-related dementia might actually be the most prevalent dementia. And then you can see Down syndrome, HIV, and then the childhood dementia. So that's just as a point of interest for understanding a little bit more about the scope or the different types of dementias that are around. In Australia, it has become the second leading cause of death. About half of the people living with dementia are underdiagnosed or underreported. And that is because I think people, when they have optics around dementia, are still looking at Alzheimer's, which is your forgetting dementia. But with the vascular type dementias, you often have personality changes, you have, you know, acopia, and that may not always be clearly understood as being part of a dementia process. And if it's presenting in people who are younger, it often has a psychiatric profile to begin with and can be misdiagnosed for many years before there's a realization it's actually a dementia process. What we know statistically is that about 54% of people living in residential aged care have a dementia diagnosis. And that's statistical information that's returned to bodies like ABS and AIHW in Australia. The real number, though, and when we're training staff, we hear that there is an acknowledgement that a lot more people have probably got a dementia, but haven't had a diagnosis made. So it is suspected that maybe 2/3 of the population living in residential aged care have got a dementia process happening. Sorry, I don't like that word, dementing. They are living with dementia and they have a dementia trajectory.
It's interesting. It's interesting, Bronwyn, also that usually dementia will coexist with other comorbidities, especially in the age population, which is what we're talking about here. So yes. I think, and that's another reason it might be hard to get a number on the figures of dementia causing death, because, you know, often people with dementia have comorbidities and one of them is going to be the actual cause of death, but the other, yes. But in the absence of all other, you know, life-limiting illnesses, it's important to note that dementia will cause death.
Yes. Yeah. And so, you know, what has become better from a reporting perspective, so when doctors are doing a death certificate now, there's a huge encouragement to document underlying causes. So, for example, you may have someone who dies from pneumonia or sepsis, but the reason why they became so unwell was through an opportunistic illness because of the damage that was caused and the deterioration caused by dementia.
Yeah.
So yeah, I think we're finding that there are a lot more records. And I think too, the more we talk about dementia, the more people, GPs, staff in residential aged care, because this is our cohort, begin to then ask for people to be reviewed from that perspective.
Yeah.
What is also clear is that there's a lot more support required. If someone is living with dementia, they have greater needs. So 84% of high-level care around cognition and behavior, 76% of high levels of care and activities of daily living, and 61% around complex healthcare, which goes back to what you were saying, Nat, about there being a lot of comorbid illnesses involved. And some of them even drive the dementia itself, so going back to the vascular type dementias, you have cardiac disease, there's also renal failure, there's also diabetes, and all of those things can actually contribute to the dementia and its trajectory. But then you've got all these comorbidities, so your burden of illness is really high. So what we know about aged care, having, both of us having worked in residential aged care, is that the things that strengthen our care for residents living with dementia is this whole long list. So for those of you who are joining in, please work through this, but I think you'll be able to tick the box for pretty much everything that's there. One of the things that we do know a lot, and this is where we capture some of this information with PACOP, is that socialization is really important. Nutritional needs. We see big changes happening with people living with dementia. And, malnutrition can be quite significant in how people deteriorate, but it can also be part of a natural journey or trajectory, from a dying perspective. So this can cause a lot of distress with families. This can cause a lot of agitation because it feels as though we're not caring for the person. But there is a normal process that happens where people start to lose interest in food, eating and drinking, become much more withdrawn, become less active. And these are the things that we see PACOP is really good at capturing and beginning to translate. Some of the information here, when working in residential aged care, you're capturing this information with your quality indicators. You may also be capturing this information around your serves. So that information that you're already collecting can inform your assessments and help to prognosticate what's happening with your residents. So how does PACOP support people living with dementia and their illness trajectory? What PACOP facilitates is a routine holistic screening of the resident every 3 months. And the things that we look at the symptoms that a resident is experiencing and the distress that they may have in association with those symptoms. We have the capacity then to do clinical evaluation and interventions, and we've got a time frame in which to respond to that. We look at a resident's performance, we look at their function, we look at their frailty, because we know that frailty, again, ties in with your quality indicators. If you've got increased weight loss, falls, changes in skin integrity, your resident is using more PRNs, they're becoming more susceptible to infections and sepsis. This is all tying into a picture of frailty, and the more frail a person becomes, the higher the risk is of mortality. We look at and document the degree of comorbidity and look at the burden of illness for the residents. We also check in on unplanned hospitalizations, because what is also known and well documented is as people reach the end of their life, their visits to hospital may increase. One of the things that we really want to support residential aged care with, especially with this program, is to be able to build confidence around being able to care for the resident in situ, so that there's less likelihood or less requirements or needs to have to send a resident to hospital.
And that's so important for someone with dementia.
Yes.
A change in environment is hugely unsettling and actually frightening for someone with dementia.
Yes, and can trigger a delirium.
Yeah.
And if you have a delirium, that can fast track the trajectory for the person. So, and I mean, you know what it feels like to have someone in emergency department who is living with dementia, and what it feels like for that person, but also how disoriented that they become. And, you know, I can remember having a resident go through to emergency department when COVID was just beginning.
Yeah.
And that resident came back, you know, with COVID. So, you know, they ended up, and how do you explain to that person who was a wanderer not to leave their room when they've got COVID?
Yeah.
So it
Yeah,
becomes, you know, so it puts them at risk when they come back. There's the risk of impacting other residents. But just generally, our residents end up becoming sedated because they're a bother. You know, people don't like them wandering around, touching equipment, etc. And then, of course, this program helps to identify palliative and end-of-life care needs, but not right at the end of that, earlier on, so that there's more opportunity to do anticipatory care.
So routinely picking up increased care needs, whether it's performance function, symptom load, distress, all of which are entirely relevant to progression of dementia with a person.
Yes. So, you know, we have people say to us, you know, every time when we're presenting this information, how do you work with someone living with dementia? I mean, and in truth, you know, when you're looking after your residents, you know them well, you know their diagnoses, so you also understand trajectories that are involved with their illnesses, and you have a group of people who care for them very closely. So our care staff do that incredibly well. When a care staff comes to us and says to us, there's a change happening to someone, the person doesn't have to be able to articulate that. We can see that. We can see that from the changes in baseline function, their mood. It becomes very clear to us that there's a change that's happened to that person. So regardless of whether someone has dementia or not, we still have the capacity to understand that there are things changing for that person.
Yeah.
So it's useful to use illness trajectories to look at advanced care planning. And that's the other thing that this program does. We encourage regular review every 3 months of the person's advanced care planning, and then bringing families in with the resident to have a conversation about reviewing goals of care. So the other thing that people often say to me is, you know, when someone is dying from dementia, what does that look like? Well, it can look like a few things, but I've picked up 4 particular presentations that I would often have spoken about when I was teaching about end of life with dementia. So you may have your changes in baseline. So, you know, your quality indicators, you can actually see this when you're doing your assessments. You can see the loss of weight, falls, all those things we mentioned beforehand, activities of daily living. Those things can in their own right be indicative of the fact that there's changes. Then you have residents who are bedbound, who need full care with all activities of daily living. And in particular, groups of people who have been, you know, one of the good questions is, what were they like 3 months ago? What were they like 6 months ago? And that gives you your tracking, your trending. So someone who's become bedbound in that 3 month, 6 month period of time, that's quite indicative of change that's happening with a terminal or a palliative need involved. People, you may already look after a group of people who are bedbound and have been for a number of years. The program still has capacity to help you to identify when there's changes associated in that group of people as they come to the end of life, particularly people at end-stage Alzheimer's disease, who end up often being curled up, fetal position, and may have been like that for quite some time. You have a group of people who have an unstable baseline, and that's often because of comorbid illnesses. So we see that in our chronic illness trajectories, and we see that chronic illness events actually speed up. You end up getting more and more of them. Seems like the person just recovers, and then they get sick again. And then you have a group of people who experience psychomotor agitation. So ostensibly, when you look at them, they are fairly independent, seem to be okay, except that they start to, there's a lot of non-purposeful movements. They're doing things that are recurring, so they can perseverate. There can be an accompanying emotional distress around that too. So, and this may occur more so with people who have a frontal lobe type syndrome of illness, dementia, because I think gradually the capacity to self-soothe and just that constant change happening in the frontal lobe creates a sense of insecurity, foreboding, fear, and the person becomes quite distressed. And this is commonly described as BPSD, although the new language around that, which I prefer, is anxiety-led behaviors. So
really, Bronwyn, what we're seeing with all this information about dementia is there's many different ways that dementia will present in terms of its signs and symptoms, but the common thread running through all of it is that there is deterioration in either across all domains or in just one or two, and that's where PACOP comes in, because we track that. We have that routine holistic screening, and it will pick up in whatever area it is, or all the areas. If it's across all areas, it will pick up that deterioration, and that's what we use to inform our care planning and care. So it's hugely beneficial.
Hugely. And, it provides that what was happening 3 months ago. It provides the answer to that question. What were they like 3 months ago?
Yes.
Because, we can live in that, the heating pot, if you like, where, the frog in the hot pot. You don't know how the changes are happening because they're so gradual.
Yes.
But being able to reflect back 3 months and have a look at what was happening 3 months ago can be very edifying. We can have such insight into what's happening.
That's right. And you have the option, of course, of grabbing that deteriorating resident tool and doing it outside those 3 monthly time points, if for any reason you're concerned about anything. And that'll just gives you that extra layer of information in between those time points if you need it.
It does. So I have a slide here, it comes from, you can see the citation for the article below there it's a recent publication. This publication was looking at illness trajectories and well-being, and it looked at chronic illness, it looked at rapid deterioration, and it also looked at cognitive changes, frailty, dementia, neurological conditions, or major stroke. So that's the slide I've chosen to really look at. What is fantastic about this slide is we often see the green line where they're talking about the illness trajectory, and people don't really look at the social, psychological, and spiritual well-being of someone. So this research has gone and looked at illness trajectories to have a look at person-centered advanced care planning, and then took into consideration how people were functioning at all those levels. So it's a really holistic representation of an individual.
What a great study.
It is. It was so interesting.
You're talking about palliative care. I mean, social, psychological, spiritual are equally, if not more important than physical.
Well, and they can often, if not well managed, they can drive a physical change.
Absolutely.
So, this is just such an interesting study. So I have chosen this, and highlighting the end of that journey is where we think that our program really supports people. So you can see here that there is that constant decline. So the cognitive decline on its own, if we're not looking at comorbid illnesses with a resident, the cognitive change on its own is gradual. And it's dementia is a very long illness. Even the shorter types of trajectories, which come to frontotemporal Lewy body, they're still years. Here, Alzheimer's disease can go for as long as 20 years from the time of diagnosis. So you see this gradual decline. But what is really interesting is just look at the green line, but look at where the red, the pink, the purple, and the orange lines change. They actually change quite ahead of the actual physical deterioration of the resident. So, when you're looking at somebody holistically and you're assessing them holistically, we need to capture what's happening to the person before there's that physical decline. So in PACOP, one of the tools that we look at, which we think is an amazing tool, it's a distress tool, comes to us from PECOC, is a specialist palliative care tool that reviews the impact of symptoms on the person themselves. And the gold standard is for the person to actually respond to that themselves too.
How does Bronwyn, can you explain how we would use this tool for someone with dementia? So often people will say, but how can they tell us? How can they tell us what they're distressing when they struggle to communicate?
So what we do have is, and because that is exactly right. How do we talk to somebody? How do we get the responses back? So question, Nat,
Yeah.
do you think that all people with a diagnosis of dementia cannot give us a response?
Absolutely, I don't think that. Like we touched on already, dementia, people with dementia, the presentation of the effects of dementia are so varied from person to person and so different from even day to day in one person.
Yes. So it is always good to start off with the resident, asking them the questions to see if they can actually give you a response. So you'll see here we've got two documents that are up on the screen there. The daily symptom assessment scale, this symptom assessment scale, we can ask the resident or their family to have a look at this and see if they can respond themselves. And the information on the left-hand side is what we give families and we give residents to see if they would like to do the self-assessment. People living with dementia can actually respond to this and work through this themselves with support, and the support can be family, can be us, and they can give us the responses with some guided support. In a group of people who have lost the capacity to understand the question, to respond appropriately to questions, or as can happen in, for example, frontotemporal dementia, where people become mute and don't have the capacity to answer anymore, there is a proxy tool. So that is what we have on the right-hand side there. So you can work through that with each of the symptoms that we're evaluating and ask questions about what's happening.
And what that proxy tool is, you probably can't see it on the screen, it's a bit small, but it's really like a description of, if you were suffering distress from this symptom, this is what it may look like if it was severe distress, or this is what it may look like if it's moderate distress. And we have those descriptors for each of the 7 symptoms that we are assessing in the tool.
Yes. And so what's also useful is if you've made an assessment on someone as a proxy, you can then use those descriptors to document what it is that you've seen and what's guided your decision. So it's very, very useful. So there's 2 ways. You can work with somebody even as they're losing capacity, see if they can do a self-assessment, have their families work with them. The hierarchy is the resident first, then families and carers, then our care staff, and then professional staff. So that's your RNs, ENs, and they're right at the end of the hierarchy. So we go from the resident first. The other things that we look at, which is what we were saying beforehand, is performance. We use the Australian Modified Konofsky Performance Status. We look at function, which is the resource utilization groups, activities of daily living, the RUG-ADL, which also is a monitor of the workforce load. And then there is the Rockwood Clinical Frailty Scale, which helps us to assess the frailty of each of the residents. How the program works with this is such a cool slide. This looks at how we migrate or transition from active treatment into palliative care treatment. And so it's never a full stop moment once you've been diagnosed with a life-limiting illness. There's this gradual movement from active treatment to palliative care, supportive care. The first trajectory up there is a cancer trajectory. The second one is chronic illness. And the third one is cognitive impairment. And with our program, the 3-monthly monitoring system that we talk about is the profile collection. And as Nat mentioned, there's a deteriorating resident tool that's involved in that process as well. So between 3 monthly assessments, you can do a quick review of the resident between times if there are changes. You'll also notice that the program that looks after, or the part of our program that looks after palliative and end-of-life care, is called our outcomes. So we look after palliative outcomes and end-of-life outcomes for the resident, hence the name. There is an overlap period where people, for example, the chronic illness trajectory, people may deteriorate quite rapidly and you may need to monitor them on a daily basis. In that situation, we would recommend you transition the resident to the outcomes collection and you monitor them daily. If they get better, you can move them back into the profile collection where you'd be looking after them and reviewing them every 3 months. So we acknowledge that people with chronic illnesses will have frailties and the frailty will affect immune systems. We also acknowledge that people with cognitive illness have often got trajectory 2 and sometimes even trajectory 1 as well. And all of that is going to then impact their end-of-life journey. So the two parts of this program work really well together to monitor your resident either every 3 months or on a daily basis from a holistic perspective.
And that's the beauty of the program, is because everyone's palliative, I mean, dying isn't an exact science. So
Correct.
everyone's palliative journey is their own.
Yes.
But PACOP as a program allows us to monitor it from very early on, you know, upon their admission to residential aged care, which is really the beginning of their deterioration, because otherwise they would be living in their homes
exactly.
But it gives us that option to you know, start as a screening profile process, capturing it every 3 months, and then when their care needs start to increase, whether that's performance, function, symptoms, a combination of all, we have that option of then putting them onto outcomes where we can give more intensive assessment and therefore response, and ideally in the last 3 months of life. But that can change because, you know, it doesn't work quite like that, you know. So that's the beauty of the program, is that you can go back into profile if you need to, or you can put someone on outcomes and monitor them. I mean, ideally, I mean, the whole program really is just making sure we capture every change, every care need as it happens, so that we can provide that care
and be responsive.
That's right. You can't, you know, the only way you can provide exemplary care and holistic care to a person is if you know about the care need to start with. You can only know about it if you're assessing. So it just comes back to that good clinical care, which involves regular assessment and response.
Yes. And, you know, a lot of aged care homes and people will say, we do this. And the answer to that is yes, you are doing it. And I know that, you know, having come, both of us, from coming back from the backgrounds we've come from, the situation that happens is that you may have new staff coming in who don't have that experience. So that's one scenario. So this provides a standardized approach to them.
And a rigorous process, you know, because
and a rigorous process.
Without a process, things tend, through no fault of anyone's, can just drop off the radar because you've got so many competing things for your time, particularly in residential aged care. So by introducing a standardized, rigorous assessment, which is part of a process, it can't get forgotten.
That's right. It gets embedded in everything.
And the aim is then that the resident doesn't get forgotten. I mean, that is our aim.
That is our
coming
aim.
back to our aim is making sure things are, you know, best possible outcomes for residents.
And this is all nurse initiated, but what is incredibly useful is with the validated tools, it changes the conversations you're having with your practitioners, be they medical practitioners, nurse practitioners, and you're providing scientific evidence around what's happening. So even as a most experienced clinician, you now have validated tools that you can take to your GPs, for example, and it changes the conversation. And we are already seeing those changes happening. So, and then of course it helps you too when you're talking to your families. So you present them with this conversation and the validated tools and the trajectory.
It's evidence, if you like. It's evidence that there's changes happening and things, you know, therefore need to be changed. Yes.
So what I have done is I've put a list here together of ongoing learning opportunities. It's a huge list and it's tiny writing. So again, it's something that will be more valuable if you can have a look at this when the recording is sent out. But there is a combination of dementia training, dementia resources, self-directed, and or facilitated, and the same too for palliative care. And a lot of that looks at palliative care in aged care specifically. So I would encourage people who are passionate about this and have a great interest to trawl through the list there and see if there's anything they've not seen before. And it includes our Indigenous populations as well and our diverse populations. So have a trawl through that and see if there's anything there of any value. These are some of the references from today's talk.
There was a question from someone to make these available, so we will definitely make them available and send them out.
No problem.
Today.
Yes. So thank you everybody for joining us today. This has been a long awaited talk, I know, and I hope that it's answered some of your questions, but all of us would be very interested to link in with you if you have more questions you'd like to ask. And Nat, thanks for joining me from WA. I appreciate you doing that.
Thanks for having me. All right. Thanks everyone for coming.
Thank you, everybody. Talk
Okay.
again soon.
Bye-bye.
Bye-bye. Bye.